Hello, everybody. So we're going to go ahead and get started. Today we're going to be talking about the 2014 HIT roadmap. We had kicked off our webinar series with this topic, but seeing as how we're into our 10th week of these webinars, we thought we would pick the best from each of the topics and talk about those. Also, towards the end of this session, we'll go ahead and unmute everybody, and perhaps we can have a more interactive discussion about any questions that you may have or any of the material that we've presented. You're also free to use the Q&A panel in your WebEx toolbar, or you can use the chat window to send either Dan or myself, Antonina, Megan Halligan. I'm using her ID. So if you wanted to go ahead and send us your questions, we can address those as well. And before I begin, I wanted to also go over our disclaimer. Nothing that we share with you is intended to be legally binding or prescriptive advice. The presentations that we've been putting together for you are a synthesis of information that's available publicly, and it's based on best practices. So with that said, we'll go ahead and get started. So we're going to talk about NextGen 5.8 and KBM 8.3 upgrades just in terms of how you might be able to prepare for these. We'll talk about ICD-10, meaningful use stages 1 and 2, physician quality reporting system, patient-centered medical home, and then ACOs. So before I get started, I wanted to go over what we've been recommending as the optimal HIT roadmap for 2014. Obviously, each organization has its own unique needs, but just in terms of all the different deadlines that we need to be aware of for 2014, we feel that this is the right sequence and the right timing for each of the activities that need to occur between now and the end of the year. So hopefully by this point, you've all finalized your roadmap or your plans for 2014, and that first on the agenda is upgrading to NextGen 5.8 if that is the EHR system that you use. And simultaneously or shortly thereafter, loading KBM 8.3 in your test environment so that you can then determine what your upgrade path needs to be. And then in Q2, and this can be any time between April and June, to apply the 8.3 upgrade to production. And simultaneously with that, to begin testing claims for ICD-10 with clearinghouses as well as with pairs. The third quarter, ideally, you want to attempt doing your 90-day meaningful use reporting, as well as train your providers and staff on ICD-10. And in the event that you do not pass meaningful use in Q3, you have the last quarter of 2014 to make up for meaningful use, and then that's also the big deadline for ICD-10 come October 1st. So the NextGen 5.8 upgrade is, as you probably know by now, is a prerequisite for KBM 8.3. And one of the reasons why it is a prerequisite is because it is ready for use for ICD-10 as well as SNOMED and meaningful use. Some of the key features of 5.8 are that the login has changed. Previously, users were able to log in either using their name and password or using a PIN. PIN was never HIPAA compliant, so that has been done away with. And then there is the advanced audit utility, and this is something that has existed in previous versions of NextGen, but it is going to be mandatory in 5.8. There is also now increased the fields now for adding race, ethnicity, and language. which allowed the patient to decline to specify whether they want to declare their race, ethnicity, or preferred language. And there's also multiple choice functionality has been added for race. Patient status designation has been added to facilitate meaningful use reporting to immunization registries. The status indicates whether the provider considers a patient to be active or inactive for immunizations within the practice. Then there is syndromic surveillance measure. This is to support role and location designation fields for reporting syndromic surveillance data for meaningful use. There's an enhanced diagnosis model, which was developed to meet meaningful use 2 requirements. And this creates 2 types of diagnosis lists. One is based on the billing ICD list, where the coding is done in ICD-10, and this is an encounter-level diagnosis list. It is used for billing, administrative, and reporting purposes. And then the other problem list is the clinical problem list, which is coded in SNOMED codes. It's at the patient level, and it is used for clinical patient care and treatment, as well as for interoperability of clinical data and reporting. The diagnosis search engine has also been enhanced. However, if you are using IMO, this enhancement would really not have a huge impact on your practice, and continuing to use IMO would probably be would probably serve you well. So for patient education, 2 education material options have been made available. There's HealthWise, which may require separate licensing, so please look into that. And then externally, you can point to any of the web-based information sites, such as UpToDate. And the interface is via HL7. HealthWise patient education can be saved to the patient chart, and monograph searches can also be saved, but you might not be able to accomplish that for web-based patient education. For e-prescribing, there is new messaging included in SureScripts. And then lastly, the patient information bar, which is at the top of the templates or modules in EHR, and it displays demographic and medical summary information on the selected patient. And this is designed to help improve the workflow. Certain items on the patient information bar can be configured from practice preferences, so you have a fair amount of flexibility in how this information bar looks. So any clients that are on non-KBM versions or on KBM 8.1 or earlier will need to upgrade to 8.3. And part of that reason is because 8.3 is ICD-10 as well as meaningful use compliant. How much cost and effort and time is invested in doing the upgrade is predicated on what version you're currently on. Similarly, the scope of conversion is based on how many customizations you have, what kind of data mapping needs to be done, as well as what workflow changes might be necessary. So this is actually a really good time for organizations to reevaluate their workflows, especially if they've been on NextGen or any EHR for a number of years. It's not very often that you have the opportunity to look at your workflows and be able to make process improvements, and so doing an upgrade is the optimal time for being able to do your workflow analysis and identify any changes that you might need to make. So you have a couple of options for how you want to approach your upgrades. One, you can do these in-house with the staff that you already have, and then the other option is to outsource the upgrade. There are some situations in which you could possibly do a hybrid of the two, where your in-house team takes the lead on doing the upgrades, but then you use an outside resource as a just-in-time resource to help guide the process along. So one of the considerations for you when you are thinking about the upgrade is whether you have the right hardware. Do you have the most current Windows operating system that will support both 5.8 and 8.3 to make sure that your Windows workstations are current, that you have an adequate server, that you have a development environment, a SQL server, and then to make sure that you have separate SQL servers for reports as well as for HQM and advanced audit. And sometimes the focus shifts so much on the application side of things that hardware may get overlooked. So as part of your planning process, it's imperative that you look at what your hardware situation is and whether you need to upgrade that before you can upgrade your software. So with ICD-10, October 1st, 2014 is the date, and it remains unchanged as of now, when everybody who's covered by HIPAA is going to be required to convert to ICD-10. As you may know that in other parts of the world, ICD-10 was implemented as early as 10 years ago and as recently as a couple of years ago. So we're going to be one of the last countries to actually be implementing ICD-10. Currently with ICD-9, there are about 14,000 different codes, and these will grow to about 68,000 ICD-10 codes. It's important to remember that ICD-10 is not going to have any impact on CPT codes. And this is the logical next step. If you remember a couple of years ago, the version 5010 standards were implemented, and those were implemented as a precursor to ICD-10 implementation. So there, as a result of ICD-10, there are going to be significant changes both to the clinical systems as well as to revenue cycle systems. The codes require fairly complex conversion. Like I mentioned earlier, if you are already using IMO, it takes a lot of the pain out of the conversion process because they've been ICD-10 ready for a while now. And they have a really cool solution which also allows conversion of historical data. So if that's something that you haven't looked into, now might be a good time to get in touch with them. Part of the reason why it's important to upgrade your software is because ICD-10 requires expanded data fields because the codes are longer, and I'll show you an anatomy of the code in just a minute. But the current systems are not designed to handle these longer codes. And obviously, along with this comes staff retraining on both the new version as well as on the codes themselves. So ICD-10 codes are very granular, and these were a set of codes that were developed by the World Health Organization to be able to improve clinical accuracy as well as disease tracking and trending. So like I mentioned, there are more ICD-10 codes compared to ICD-9, and this little infographic gives you a comparison of the two. The key differences, of course, are that ICD-9 codes are just 5-digit numeric codes, whereas ICD-10 codes are 7-digit alphanumeric codes. So there is a lot of room for expanding ICD-10 codes. Sorry, my mouse seems to be working too fast. So there are two types of ICD-10 codes. There are the diagnosis codes, and then there are the procedure codes. The diagnosis codes are anywhere from 3 to 7 digits, where the first digit is an alpha, and it includes the letters O and I, but it does not include the letter U. And this becomes an important distinction and you'll see this as once I start talking about the procedure codes. The second digit in this code is numeric, and then the third to seventh digits are alpha. These are not case sensitive, or these could be numeric. There's a decimal after the third digit, and so I've given you a couple of examples. In the first instance, it's a short code for Q fever, so there is no decimal. But then in the second and third examples, you can see a decimal after the third character. And the last example is actually the perfect example of an ICD-10 code because it gets to a very granular level of detail, which includes exactly where the fracture is on the body and what type of a fracture it is. So these are, so the ICD-10 procedure codes are 7 digits. They're alpha or numeric, and the alpha is not case sensitive. So in this instance, the letters O and I are not used, and the purpose is to avoid any confusion between the numbers 0 and 1. And there is also no decimal. So here you have a couple of examples. Of one is an excision of liver percutaneous approach, and then the other one is the repair of upper esophagus. And it tells you exactly what kind of a procedure it was, whether it was diagnostic, whether it was an open approach, or whatever the approach may have been. So the other thing that you've probably been hearing about is SNOMED. And SNOMED is the acronym for Systemized Nomenclature of Medicine, and the CT extension is for clinical terminology. This is an international standard for clinical terminology, and it is available for no cost through the National Library of Medicine. The primary goal of SNOMED is to enable communication in between providers and EHRs in a language that's common. And the objective is to increase the quality of patient care across multiple specialties, as well as to improve the accuracy of data analysis. So there are a total of 19 hierarchies that define the clinical concepts. And unlike the billing side of the code, SNOMED, because this is purely for clinical use, has far greater granularity. It's very, very specific to clinical concepts so that the patient's condition can be accurately defined. And the hierarchy of SNOMED is far more complex than ICD-10. So you may be wondering, what's the relationship between ICD-10 and SNOMED? So SNOMED has better clinical coverage than ICD-10 does. As an example, SNOMED has 100,000 codes for clinical findings, whereas ICD-10 has 68,000 codes, and of course ICD-9 has 14,000. The focus of ICD-10 is more statistical, and so there's a lot of the less common diseases become subsumed under general categories. And most importantly, ICD-10 codes are applied after the fact, whereas SNOMED is clinically oriented, and these codes are used during care. And they have far greater clinical relevance, and they're user-friendly for the providers. Clinically coded data will generate ICD-10 codes for billing purposes. So if you want to think about, for now, if you want to think about a table with 3 columns, where one column is your ICD-9 codes, then the second column is ICD-10 codes, and the third column is SNOMED. Each ICD-9 code maps to an ICD-10 code, or it may map to several ICD-10 codes actually, and then each ICD-10 code maps to one or more SNOMED codes. And I also just wanted to mention that part of the reason why we're even hearing about SNOMED is because for meaningful use, providers are required to report SNOMED codes. And again, if you are using IMO or if you're considering using IMO, you might want to talk to them about their solution to handle historical data, because you may be able to code encounters and diseases moving forward, but IMO also has a solution to apply these codes to historical data, which is really valuable. So an effective implementation strategy for ICD-10 is to begin with an impact analysis where you identify all your current systems and work processes that are that ICD-9 codes, where ICD-9 codes are used. And hopefully you are past this stage, because according to the CMS, the conversion to ICD-10 is about an 18 to 20-month process. So hopefully you're somewhere along the lines of getting closer to conversion, but I just wanted to go over what the most effective implementation strategy is, so that if you've overlooked any of these aspects, you still have a little bit of time to go back and address those. And as part of your impact analysis, having a conversation with your peers about the effect of ICD-10 implementation is critical. And then the next stage of this process hopefully was or will be is to review your workflow and business process changes, as well as identifying staff training needs and making sure that whatever vendors you're working with are also ready for the move to ICD-10. If you don't already have a project plan, this would be a good time to put one together, so that you have a well thought out implementation plan with clearinghouses, billing services, and pairs. And this is also a good opportunity for you to inventory all your systems and workflows that are going to be impacted by this conversion. And most importantly, to have a contingency plan for, in the event that something were to go wrong with your go live, you need to have a contingency plan, because come October 1st, you won't really have the flexibility to not bill using ICD-10 codes if you want to get reimbursed. You may already have thought about your the costs and the time that is associated with the training as well as the upgrade. And then you might have already looked into, or you might want to look into assistance from outside vendors and consultants. I've talked about IMO as being one possible resource for you. I believe Navicure is another organization that can be of tremendous help. And then you need to think about any potential productivity loss. It would be utopia if there were to be no productivity loss, so you do need to be realistic about providers having a learning curve that might make their productivity drop, at least in the first week or two of implementation. And then, of course, there's the conversion, making sure that you have tested all your transactions using ICD-10 codes, that you're able to transmit transactions and also receive explanations of benefits that use ICD-10 codes. I've talked about this too, making sure that your historic data has been converted, or you have a strategy for doing that conversion. And then to review your coded data for claims reimbursement to make sure that how your coding is consistent with ICD-9 rates. So here are some tips on training for ICD-10. Ideally, you don't want to train your staff too soon unless you're also planning to do a refresher. So the optimal time frame is within 6 months, but I think closer to August or September, especially for your providers, is probably more optimal. For your billing folks, they may require a couple of different levels of training, so they may benefit from one fairly early in the process and then another one that's closer to October 1st. So and again, these are just general guidelines. These are not mandates, but approximately 16 hours for ambulatory coders, and then about 50 hours for hospital coders. And the reason for this is that ambulatory coders only need to learn ICD-10 diagnosis coding, whereas the hospital coders need to learn both the diagnosis as well as the inpatient procedure coding. So it's a little bit more complex. There are lots of specialty-specific ICD-10 training programs available in the market, and there are also programs that integrate into credential maintaining CEUs, so that might be a good opportunity to invest in your staff development. And then there are lots and lots of resources available through CMS as well as through professional associations and societies. So now we talk about meaningful use. So meaningful use, as you know, are a set of standards that have been defined by the Centers for Medicare and Medicaid. And there are financial incentives that are offered for the use of certified EHR technology. And in order to be eligible for these incentives, eligible professionals need to demonstrate that they're using their certified EHR technology in a meaningful manner, that they're using this for electronic exchange of health information, and that they're also submitting their clinical quality measures. So there are 3 stages of meaningful use. The first stage, which is meaningful use 1, is focused more on creating information. Then stage 2 focuses more on exchanging information, and stage 3, which is going to be implemented January 1st, 2017, focuses on improving outcomes. So this is just a visual that shows you what the different stages are. If you participate in Medicare, you would not have had an adopt, implement, or upgrade step. It would have been just meaningful use 1. In order to be eligible for meaningful use 2, eligible professionals need to demonstrate that they've participated in meaningful use 1 for at least 2 years. And you might be aware of an announcement that came out late last year. It was a little bit of a misleading headline because it talked about meaningful use being delayed. Meaningful use 2 being delayed, but meaningful use 2 wasn't delayed. It's just been extended by a year. It was originally scheduled to go through the end of 2015, but it's been extended by a year, so meaningful use 3 has been delayed. So like I mentioned, meaningful use stage 1 is about information gathering. Eligible professionals are required to participate in it for a minimum of 2 years. In the first year, the reporting period is only 90 days, and then in the second year or the third year, it's the full calendar year. It's also important to remember that there are actually 2 different schedules. Hospitals and critical access hospitals are on a different schedule because they follow the federal fiscal calendar for reporting, whereas eligible professionals follow the calendar year. Stage 2, like I said, professionals must meet meaningful use for at least 2 years. In some instances, this would be 3. Stage 2 is focused more on advancing clinical procedures, and so there's a lot of emphasis on health information exchange, as well as e-prescribing and lab results requirements, and as a matter of fact, also diagnostic results. Continuity of care across multiple settings, which is a very common refrain that you hear in patient-centered medical home, is an integral part of meaningful use too, and also increasing patient and family engagement. So the ultimate objective of this stage is to improve patient care. And this is just a comparison of the differences between MU1 and MU2. The number of core measures in MU2 has gone up, and some of the measures that were menu objectives in stage 1 have now become core measures in stage 2, and the thresholds have increased in stage 2. The number of menu objectives has decreased. So in stage 1, EPs needed to have 5, report on at least 5 menu objectives, whereas in stage 2, they need to report on 3. And so there are a total of 20 objectives for stage 2 compared to 18 for stage 1. The requirements for meeting meaningful use are that and the first part applies to all providers, irrespective of whether they're attesting for Medicare or Medicaid, but they essentially need to adopt or upgrade to a newly certified EHR. And then if they're reporting for Medicare, only in the first year can providers choose any 90-day reporting period. And then beyond that first year, it's based on the federal calendar, and if they're reporting like in 2014, they will be reporting for a reduced period, but it needs to coincide with the calendar quarter if this is not the first year that they're reporting. And in Medicaid, it's any 90-day reporting period. It doesn't have to coincide with a calendar quarter. And one of the key things for meaningful use this year is patient portal, whether it's stage 1 or stage 2. So if this is something that your organization hasn't yet thought about, this would be a good time to look into implementing the portal, because for stage 2, it's not just a question of having the portal in place, but it's also being able to demonstrate that 50% of your patient population is registered to use the portal, and 5% of your patient population actively uses the portal. And active use includes being able to schedule appointments, as well as being able to request medication refills and being able to communicate with their providers. So the meaningful use calculations basically are based on the denominator, which in all instances is either all unique patients or for clinical quality measures, a subset of unique patients. And then the numerator is the number of unique patients for whom the required information has been recorded. And to calculate the threshold, you would divide the numerator by the denominator. The reporting is done through attestation through the CMS website. You may have seen the news release. The deadline for reporting for attesting for meaningful use was February 28th, but this has been pushed back to March 31st. The reporting includes the core measures, the menu objectives, as well as the clinical quality measures. Some of the reporting is based on numerator and denominator attestation, and others is based on yes or no answers. So there are some exclusions where not all menu objectives are applicable to a specific practice. So be sure that you read up on whether your practice can be excluded from certain menu objectives or not. A primary example of this would be if your local public health office does not have the capability to accept syndromic surveillance data electronically, then you can claim an exclusion for that. Similarly, some objectives or measures require that 80% of the patients have a record in your certified EHR technology, so be sure that you read through the user guidelines before you start your attestation process. CMS actually makes available a really helpful tool on their website, which is an attestation worksheet, and it allows you to plug in all the data before you sit down to start the attestation process. Here's an attestation checklist. Make sure that all your eligible professionals are properly registered. Run your reports for the correct period, and make sure that you keep your reports on file. In the event that you are ever audited, you want to make sure that you have everything available. You need to validate data. If something doesn't look right, don't just report it. You do need to make sure that the data is representative of what actually transpired during the reporting period. So like I was mentioning, complete the attestation worksheet because it takes a lot of the guesswork out of doing the attestation, and you can move through the process much faster. Make sure that you have all your supporting documents. So one of the things that you're going to need to have is your EHR certificate number, and then if, for example, you need to talk about what clinical decision support rule you've turned on, make sure that you have all the screenshots and all the information available on hand. So I mentioned earlier that the deadline for attestation is March 31st now. However, if you're attesting for Medicare Advantage organizations, the deadline remains unchanged. It's still March 1st of this year. And then be prepared for an audit. You may never ever be audited, and that would be totally cool. But there may be a time, perhaps not this year, maybe next year. But you always need to be prepared for an audit. So being able to retain all your documentation in a binder is critically important. And it's always a good idea to organize your binder so that you have like a table of contents and you can locate information as needed. So this is a topic that we covered just last week. So if you had joined us, this may look very familiar. We had talked about the Physician Quality Reporting System, or PQRS. And this is a voluntary individual reporting system, which is really designed to look at quality measures for the Medicare patient population. This does not, PQRS is not a requirement for providers who do not see Medicare patients. The program was started in 2007 as a result of the Tax Relief and Healthcare Act. And the CMS it offers incentive payments for participation through the end of this year. Starting from next year, from 2015, there's going to be a financial penalty, or what the CMS very nicely calls a payment adjustment for non-participation. And the payment adjustment is compounded, so it sort of starts to grow very quickly. And you should note that reimbursement for PQRS and reporting is there's a 2-year lag between the year that you actually collect the data and the reporting period. The PQRS measures are based on combinations of CPT and ICD-10 codes, along with what the patient's age was at the time of the encounter. So a couple of different methods for providers to report. One is to do it as an individual, and that is there are a few different options. They can report either using their certified EHR technology, through a vendor of a certified EHR technology, through a qualified PQRS registry, or through a qualified clinical data registry, or through claims that are submitted to CMS. And then there's a group practice reporting, which is through the GPRO website or a registry. So the measures, there are, for individuals, there are 110 claims-based measures and 201 registry-based measures, as well as 64 EHR measures. And these cover pretty much all possible conditions and comorbidities even. There's the group measures. There are 25 group measures, and then these are the 6 domains. So you have to select a minimum number of domains to report from. Clinical process and effectiveness, there's patient safety, there's population and public health, the efficient use of healthcare resources, care coordination, which is a big focus for pretty much all programs, whether it's meaningful use, whether it's PCMH, whether it's PQRS, and then of course patient and family engagement, which is also a common theme for all the programs. So it's really important that you choose the right measures for reporting for PQRS. You don't want to create an additional layer of complexity by measuring something that your practice is not already proficient in or where you're not already collecting data. You also need to look at how relevant the measure is to your practice, and then pick the measures that represent your best performance. So there are over 200 quality measures to choose from, and you need to meet 50%. So there is a threshold, and you need to meet that threshold for 50% of your measures. And then to avoid, you have the option of selecting whether you want to get an incentive payment, for which the criteria are somewhat different to if you choose to simply avoid the penalty. Now, this is not something that's mandated for 2014, but a lot of organizations are going this route. So we just thought we would, give you a very quick overview on patient-centered medical home as well as ACOs. If that is something that you are considering doing this year, then you need to build that into your roadmap as well. So PCMH is a transformative model for the delivery of care. It basically espouses a team-based approach that focuses on the whole person. It's relationship-based, it's team-based, and the most important thing is that it's patient-driven care that is based on best practices. So in order to transform into a PCMH, a practice needs to demonstrate that it's constantly innovating, that there are measures in place to look at key performance indicators, that the practice capitalizes on the benefits of EHR. Regular patient communication is a big focus for PCMH, as well as being proactive in scheduling patient follow-up, expanding access to care, and of course, coordinating patient care across multiple settings. So there's the NCQA is kind of the de facto accrediting or certifying organization. There are others, but NCQA has the largest market share, and so their recognition process is based on doing a complete self-assessment to identify where any gaps may exist between what the NCQA standards are and where your organization is at the time you're doing the self-assessment. You need to make sure that all your P&Ps have been in effect for at least 90 days. NCQA is pretty strict about this requirement, and you need to identify all the different reports that you need to run in support of your application. There are some that need to be run over a 5-day period, others that need to be run over a 1-week period. So be sure that you run your reports based on the specific requirements for the factor or the element that you're reporting on. The application process is all online. It's a very intense process, and it's critical that you collate all your supporting documents before you begin the application process, because that will enable you to go through the process more efficiently. And then lastly, just wanted to talk a little bit about ACOs. So this is kind of a logical next step to a patient-centered medical home. It focuses on a coordinated care that ensures that there is a seamless transition between services as well as between levels of care. If you participated in our presentation on PCMH, you might have heard me talk about patient-centered medical neighborhoods. These are essentially the specialty equivalent of a patient-centered medical home, which is more primary care focused. The amount that is reimbursed under an ACO model is linked to achieving specific quality measures as well as being able to reduce costs. And the program was launched in 2012. So some of the technology infrastructure criteria for ACOs is to make sure that you have an effective revenue cycle management program, you have an EHR, that you participate in an HIE, that you have a strong focus on informatics as well as patient engagement. And then here are some of the technology considerations. I talked about patient engagement, but also privacy and security, data aggregation. Population health management is another feature that is becoming very, very common to all the different programs. So that's also a key in with ACOs, the ability to exchange clinical and administrative data, measure performance, having a strong reporting infrastructure, and then, of course, having something to support the financial aspect of a practice. So I just wanted to share a couple of informational slides on what the startup costs are for, if you are considering becoming an ACO, and I've broken this down by beneficiaries. So the highest startup costs are if you are catering to 16,000 to 25,000 beneficiaries. And then these are the IT costs. I've given a comparison of what these costs are for internal IT as well as for external vendors. And it's interesting to see that it's the 15,000 to 25,000 category that has the highest costs associated with it. That pretty much is our presentation, and I will, I haven't got any questions in the question panel, and I don't have any questions in the chat panel. So what I'm going to do is I'm going to go ahead and unmute you. If you have any questions, feel free to ask, and we will try and answer your questions. So everybody is now unmuted. Go ahead and if you don't have to ask a question, you're welcome to begin a discussion. We have about 8 minutes. So if you want to have a quick discussion, this would be a good opportunity for you to exchange ideas and maybe even learn from each other's experiences. So the floor is all yours.
Tamina, I have a question.
Yes.
This is actually something I get a lot. Can you
yes.
explain how PCMH and ACO overlap and interact with each other?
Yes. So if you were to think about a continuum, PCMH would be, if you were to start with PCMH as it's sort of a precursor to becoming an accountable care organization, in that the two have a very similar approach. They're both focused on ensuring a coordination of care as well as treating the patient as a whole person, so they're very holistically oriented. And in order to be an accountable care organization, you need to have achieved the principles of patient-centered medical home, because without that, trying to focus on quality measures that help you get reimbursed for ACO incentives becomes really, really challenging. So I guess the best way to look at it is as a continuum, You don't have to be an ACO to be a patient-centered medical home, but it's very challenging to become an ACO if you're not already a patient-centered medical home. Does that help?
It does, thanks.
All right, well, it looks like we don't have any other questions. So next week we're going to talk about project implementation, and we'll talk about it more from the perspective of technology-based projects, but we'll also talk about, if you are thinking about becoming a patient-centered medical home or an ACO, so we'll talk about that as well. And then the following week, we're actually going to be inviting Ben to come and talk about Medicare Advantage. So if that's something that has been on your mind, it would be a great opportunity for you to come and listen to everything you need to know about Medicare Advantage. Thank you very much for joining us today, and we look forward to having you online next week. Have a good day. Bye-bye.